Hi, everybody. My name is Michelle Cordova-Kazee. I'm an endocrinologist here in Edinburgh, Texas. I work at DHR Health System, and I also supervise students and medical residents at the University of Texas, Rio Grande Valley. So today I'd like to talk to you about endocrinology emergencies, not an oxymoron. So for endocrinology emergencies, what you're going to want to remember is give steroids and call me in the morning. Just kidding. So for the disclosures, I have no conflict of interest, no off-label use of medications. These are the topics we're going to be discussing today. I purposely didn't do anything with diabetes, hyperglycemia. I think at this point, most hospitals and emergency rooms have protocols for those. So for a pheochromocytoma, let's start out with a book presentation. I think if you're taking board questions, you'll know what the right answer is when you see something with a classic triad of headache, sweating, tachycardia. Keep in mind though, nowadays, most patients with a pheochromocytoma actually don't have all of these symptoms like this. Headache is most common, and that can occur in up to 90% of patients with a pheochromocytoma. Diaphoresis in a little bit over half of the patients. Keep in mind this is not flushing. So with a pheochromocytoma, you're going to be getting catecholamine surges and metanephrine surges. So that's kind of like they're getting high doses of pressors, right? So they'll be really vasoconstricted, kind of cold and clammy extremities, not a hot, warm flushing. So sometimes I've gotten consults for flushing, rule out pheochromocytoma, but that's not really how these present. Other symptoms I think we know can include palpitations, dyspnea, weakness, and panic attack-like symptoms. So that was the board kind of presentation. But what I think you're more likely to see in the emergency room is nodules. Nowadays that we're doing more and more imaging, we're much more likely to diagnose a pheochromocytoma after it was incidentally imaged on a CT scan, for example. So just be careful about sending people with thyroid and adrenal nodules to elective surgery. So you might be asking, why did I include thyroid on this slide? Keep in mind that thyroid nodules, now not all thyroid nodules need to be biopsied, but you need to consider what if this person actually has medullary thyroid cancer, which is very rare, but if you did get a biopsy back that said medullary thyroid cancer, we would all consider, wow, what if this person has MEN2 and they actually have a hidden pheochromocytoma? So certainly there have been case reports of people going to surgery without biopsying their thyroid first, and they're planning an elective thyroidectomy and have very bad anesthesia outcomes because they go into hypertensive crisis just because they had a hidden pheochromocytoma. So anytime I see a patient going to an elective surgery with an adrenal nodule, we certainly need to work that up. Some of the thyroid nodules, not all of them, do need a biopsy. In contrast, you do not want to ever biopsy an adrenal nodule until you have made sure that they do not have a pheochromocytoma. So what you want to do is check urine or plasma metanephrin prior to even considering a biopsy, which usually it's not recommended to biopsy an adrenal nodule anyway. So say somebody has metastatic disease, sure, you might want to maybe biopsy an adrenal nodule, but only after you've ruled out that it's not a pheochromocytoma. Probably in the emergency room, and I think we'll talk about this in a slide or so, you're probably going to want to get plasma metanephrins. The urine metanephrins is a 24-hour urine collection, whereas the plasma is just a one-time draw. All adrenal nodules, regardless of their size, do deserve a workup to assess for Cushing syndrome, pheochromocytoma, and if the patient has hypertension, we also want to rule out primary hyperaldosteronism. There's been a lot in the literature recently about how primary hyperaldosteronism is probably very underdiagnosed in the United States. So for the diagnostics, you want to get a 24-hour urinary, so the 24 hours for the urine, fractionated metanephrins, the plasma is just a spot check. And then urine is preferred in most cases, but like I said, probably not in the emergency department. Plasma for high suspicion or when 24-hour urine collection is difficult, i.e. the emergency department. Do keep in mind with the plasma, if your patient's in the emergency department, they're there for a reason. They're probably stressed out. Somebody's coming at them with a needle. So the plasma fractionated metanephrines can be a little bit elevated, and that can be normal, just a normal response of adrenaline due to stress. So for us to consider positive diagnostics, typically in the patients I've seen with pheochromocytomas, we're talking 2 to 3 times the upper limit of normal. So really elevated metanephrines that we're seeing. You can get an abdominal CT or an MRI. CT is preferred. Most institutions now do have an adrenal protocol. Now keep in mind, when we see an adrenal nodule, we're kind of thinking of 2 things. One is this adrenal nodule active? So that's why we work it up for the Cushing's, the pheochromocytoma, and the primary hyperaldo. But then the next question is this adrenal nodule malignant? And so that's really where the CT comes in. Sometimes I've seen my residents get kind of tripped up on that, like, oh, the CT's fine, end of workup. Well, no, you can still have a benign lesion on CT that's still very hormonally active. So you can do a CT protocol, and what that does entail usually is giving some IV contrast, and what you're going to want to look for is how quickly does that wash out through the adrenal gland. The treatment of pheochromocytoma, again, the book answer is always phenoxybenzamine, which is an alpha blocker. It's very expensive. Medicaid won't cover it. Most insurances won't cover it. I think I've prescribed it once. I've tried to prescribe it a lot, but I think a patient has taken it once. Usually we do have to switch to some other alpha blocker, maybe nifedipine, in an attempt to do the alpha blockade. And you just keep increasing the alpha blocker until the patient pretty much has borderline orthostasis. As a result of this, some people do develop tachycardia. And so once you've done a complete alpha blockade, you can introduce a beta blocker, something like propranolol, short acting. That's mostly done for tachycardia. And then you can convert it to a long acting beta blocker. This is mostly done in the setting that we're trying to get somebody ready for an adrenalectomy. Beta blockers should never be started first, which again looks good on paper, but practically I see it a lot, and I don't blame whoever's giving these people beta blockers, because if somebody walks into your emergency room and they're like, geez, I feel really anxious and I have tachycardia and I have a headache and hypertension. Yeah, you might get a beta blocker. So I've seen a lot of people who have symptoms, they get started on a beta blocker, and then only later is it discovered that they actually have a pheochromocytoma. So we have to stop the beta blocker and start the alpha blockade. Ultimately, these patients should be referred for an adrenalectomy. Beyond the adrenalectomy, now there is a lot of literature about who needs genetic testing. There are way more syndromes since the last time I took boards. Every year they're like adding more and more syndromes that we need to know about in terms of what are the familial syndromes that can give you a pheochromocytoma. So consider doing genetic testing as well. So moving on, we'll do thyroid storm next. And so I think we all kind of are familiar with the thyroid storm presentation, which is an exaggeration of the usual symptoms of hyperthyroidism. Now, how you distinguish between hyperthyroidism or thyrotoxicosis and thyroid storm is you're going to want to look for end organ damage. So, with routine thyrotoxicosis, you really should not be seeing hepatic failure, jaundice, CHF, those are, delirium, psychosis. No, this is clearly having end organ effects on this patient. That meets the criteria for thyroid storm. That being said, I do think it tends to be overdiagnosed. Like I said, I work a lot with residents. If they haven't seen a lot of thyrotoxicosis, it can be shocking. People can overreact, but really they need to be quite sick with end organ damage to meet the criteria for thyroid storm. I like to think of it as kind of, the difference between hypertensive urgency versus emergency in terms of needing to have that end organ damage to meet the criteria. So unless the patient really has severe and life-threatening symptoms, they actually don't have thyroid storm. There is a score that you can calculate on UpToDate. I'm not a huge fan of this score. I think it tends to over-exaggerate some of the problems with thyroid storm, which again, I suppose, you're better off getting it wrong on the, like over treating the patient than under treating the patient. But a problem I have with the score is, you know, the residents will do the score, they'll call me like, this patient has thyroid storm, and then they tend to like give everything all at once without trying to see like, okay, is this patient getting better with the usual thyrotoxicosis treatment? So for the diagnostics of thyroid storm, obviously you want to check a TSH or free T4. Go ahead and look at the liver enzymes, make sure that they're not jaundice or having liver failure. Keep an eye on the vital signs. Temperature is great. We tend to kind of overlook that one, but you know, if there's no other reason for it and the patient's having hyperpyrexia, that's, you know, concerning for the thyroid storm. Consider doing an echo if the person is going into atrial fibrillation or their heart is just kind of burning out from all this like tachycardia. They can certainly go into heart failure. The initial presentation TSI antibodies are usually not recommended. It's not really going to affect your treatment. The treatment would be a beta blocker and then a thionamide. We'll talk about that in a little bit. That includes propylthiouracil and methimazole. Iodine solution. So again, if you go onto a site like UpToDate, it's going to say, go ahead and give iodine solution to a patient that has thyroid storm. But my concern is a lot of the patients actually don't have thyroid storm. They get like all of this thrown on them. Everybody ends up with iodine solution. I would say consider asking your friendly endocrinologist first. I think I've given iodine solution maybe once because really, you know, the first two treatments work. So if you know, give them a beta blocker, give them a thionamide, they tend to get better pretty quickly. If they don't, yeah, sure, consider the iodine solution. But I see a lot of people getting iodine that I'm like, oh, they probably didn't need it. And down the road, sometimes I can kind of mess things up because if the patient gets a huge dose of iodine, then we have to wait in the outpatient setting. We can't do a thyroid uptake. We can't do a thyroid ablation until they've gotten rid of all this the iodine dose they got. We'll talk about glucocorticoids in a little bit as well. So for the beta blockers, again, propranolol, that can be given both IV and orally. I like propranolol in the outpatient setting because it's short acting, you can sort of titrate it. I'll have my patients take their pulse and you know, with symptoms as well, they can take a little bit of propranolol while they're waiting for their definitive treatment for the hyperthyroidism. You could certainly do a beta blocker drip. Going on to the thionamide, so PTU, and methimazole, they both block hormone synthesis within 1 to 2 hours, but they don't affect what's already in the blood or what's already formed in the thyroid. So again, you're blocking the synthesis. The thyroid's full of thyroid hormone. And so an example is I was consulted on a thyroidectomy case. So a patient had a surgical thyroidectomy. It was difficult. I think the surgeon had to like pull on things a little bit. And so post-op, the patient was thyrotoxic, had some hyperthyroidism, and the patient was on methimazole. And I was like, well, that's not going to help this patient because their thyroid is actually in pathology. So I just stopped it. I mean, the patient was pretty stable. So I just stopped all of the medication because they didn't have a thyroid. So within a day or two, their thyroid hormones came low, and actually we needed to start levothyroxine. But my point is just to consider, it's not like methimazole or PTU. They're not going to like sequester already formed thyroid hormone. But propylthiouracil, the PTU, does have some effect in that it blocks the T4 to T3 conversion. So maybe there's a little bit of a role for giving somebody PTU, and we'll talk about that in a little bit. In general, methimazole is preferred over PTU with the following exceptions. So first trimester of pregnancy, you want to give PTU. Second trimester, you switch to methimazole. Thyroid storm, like I said, the benefit that PTU would have over methimazole would be the conversion of T4 to T3 blockade. So again, if you have a patient who's very sick, giving the PTU might lower that T3. And remember, T3 is really what's driving a lot of the like bad cardiovascular effects. If the patient's unable to take methimazole, you can consider PTU, although there is some cross-reactivity. If a patient has like anaphylaxis to methimazole, I think most of us would not even try to give PTU. Um, the concern was in about 2009, there were several reports of severe hepatotoxicities and people died with the PTU. So since then, really the recommendation is to always favor methimazole over PTU with those following exceptions, or with those preceding exceptions. I just checked, methimazole is about $20 for 90 days at HEB. In terms of our uninsured patients, there is some thought that actually the initial upfront cost of a thyroid ablation and then subsequent levothyroxine is probably less expensive than continuously giving methimazole for years, just because with methimazole you have to continuously like check it and adjust it. Excuse me, which results in a lot more doctor's visits and costs, whereas yes, ablation can be expensive at once, but long-term it's probably less expensive than continuous methimazole. So like I said, with the PTU, that can block the T4 to T3 conversion. You can give it either orally or via nasogastric tube. You can suspend it for rectal administration. Your pharmacists and nurses will totally love you for this. I recently had a patient who was pregnant, had some psych issues, and she had hyperemesis gravidarum. And she was pretty thyrotoxic. So we did go ahead and give her an enema with, I think at this point she was already on methimazole. And she was with it, she consented it to the administration, but it was difficult to go online, find how the dosing was and everything. It says that it can be prepared for IV administration, but with this most recent patient, we were unable to obtain IV thionamide, so that's why we went with the rectal enema. So I included this slide just to remind us that what we're really trying to do is block that T4 to T3 conversion, and there's 3 ways we can do that. So it's kind of like we're attacking the same problem with 3 different things. So the beta blockers and the glucocorticoids, they're going to block that T4 to T3 conversion, and then PTU of the thionamides will block that as well. And then for the next step, we'll go on to the myxedema coma. In contrast to myxedema coma, I think, thyrotoxicosis or thyroid storm tends to be overdiagnosed. I've seen myxedema coma missed a couple times, and it's because a lot of times the patients are just kind of quiet, slow, and sitting there. They're not very agitated, they're not causing a scene, and I've definitely seen people kind of later in the admission where they get admitted maybe for CHF or sepsis or something like that, and we kind of miss that they either should be or were taking thyroid hormone, and then a week or 2 into the admission, somebody checks the TSH and whoops, it's quite high. So usually you'll see decreased mental status, hypothermia, hypotension, bradycardia. Hyponatremia is really common when people have myxedema coma. I don't think I've ever seen a normal sodium. It's usually low. Hypoglycemia is another presentation, and then hypoventilation. You'll get this puffiness of the hands and face, a thickened nose, a hoarse voice. Like I said, it tends to be underdiagnosed, and again, I think some people think like you have to have a coma to meet the criteria for myxedema coma, but really it's that kind of end organ damage scenario of severe hypothyroidism. I don't think I've ever seen an actual coma. I mean, I've seen people intubated and sedated, but I don't think I've seen like a spontaneous coma from myxedema coma. So this is a great picture because you can see before and after treatment, and you can just see she's, the thinning hair, really puffy eyes, nose, lips, and then she looks much better when she's given levothyroxine. So diagnostics would be a TSH, free T4, cortisol. We'll talk a little bit more about the cortisol in a bit. Just keep in mind that the TSH is a pituitary hormone. It's not from the thyroid, so it doesn't really indicate the degree of hypothyroidism. So my point is, and it's also exponential. So if you have a mild, if you have an elevation of TSH, you can't really say that like the difference of a TSH of 50 versus 100 versus 300, like one is worse, like that patient is worse off than the other, because it just is telling us how overactive the pituitary is. Like I said, most people will have a hyponatremia. So again, another point would be if I had an 80-year-old patient with a TSH of 12, But also hypothermia, bradycardia, and hyponatremia, yeah, I would get out of bed to go see that patient, because this person could certainly have a myxedema coma just because they have a tiny little shrunken pituitary gland, and a TSH of 12 is all they got. Whereas I have seen a guy in the emergency room with a TSH of over 100. He was covered in vitiligo. He was just chatting with me in the ED. He had like no thyroid hormone on board, but he didn't have myxedema coma. He was very compensated. So the treatment would be thyroid hormone, glucocorticoids, glucocorticoids and supportive measures. The levothyroxine can be given intravenously. Remember the lady, with the puffy eyes here, if her eyes, lips, face looks like this, you can just imagine that she probably has quite a bit of GI edema. So if you give her a pill, it's probably just going to sit there for a while. So I'll usually give a dose of IV levothyroxine for maybe a day or two before I convert over to oral. You can consider T3. I'd be really careful about it with cardiovascular patients. Again, the T3 is sort of the more active thyroid hormone. I rarely need to give it. Usually once you give levothyroxine, especially IV, people start to perk up pretty quickly. I was not able to get it IV the last time I tried. It is available orally. So going on to the glucocorticoids, we'll talk about that here. So until the possibility of coexisting adrenal insufficiency has been excluded, we need to give glucocorticoids. So you might be asking, like, well, why? What does the thyroid have to do with the adrenal gland? Well, the two presentations that you're going to see with the hypothyroidism would be, number one, routine Hashimoto's primary hypothyroidism. The thyroid's not working, but that tends to be driven by antibodies, TPO antibodies. So if patients are making antibodies against their thyroid, they can also make antibodies against their adrenal glands, so which would be Addison's disease or primary hypoadrenalism. And so if they have like a lot of autoimmune diseases, they could have a primary adrenal insufficiency. Secondly, what if the patient has a pituitary problem? So their pituitary is not working. That's why their thyroid is low. Well, certainly, they could have the risk of not making ACTSH, which can give adrenal insufficiency. So until you've really ruled out that their cortisol is okay, then it is recommended to give glucocorticoids for these reasons. Supportive measures, mechanical ventilation if indicated, passive rewarming of the patient. You don't want to do it actively due to the vasodilation. A lot of people do present with an infection, like they're kind of skating by on minimal hypothyroidism, and then they get an infection, which kind of pushes them into the myxedema coma. Be careful with the IV fluids with hyponatremia, and then it's certainly okay to give vasopressors for hypotension. This is a tricky question. So 33-year-old female seen with a frontal headache and blurry vision. She's had amenorrhea. Her pulse is 58, and she has bitemporal hemianopsia. Breast examination reveals galactorrhea. Her skin is cold and doughy. She has prolonged deep tendon reflex relaxation phase, and her prolactin is elevated. Normal prolactin is usually less than 20, thereabout, and so certainly 85 is elevated. TSH is 80, free T4 is undetectable, negative HCG. An MRI shows an enlarged pituitary gland that abuts the optic chiasm. So what's the most therapeutic approach? So again, this is a pretty tricky question, but that being said, a medical student should be able to get it right. So our options would be transsphenoidal surgery, bromocriptine, octreotide, levothyroxine, gamma knife, pituitary irradiation. So looking at this, I think a lot of us will notice, this person has an elevated prolactin, some galactorrhea, so there's something going on there. What's going on with this pituitary gland? So I know it's tricky. A lot of people would want to go for the dopamine agonist bromocriptine. In this case, though, the answer is actually levothyroxine. The reason being is, if you look right here, just let's focus. If we only had a TSH of 80 and free T4, what does that mean? And the free T4 is undetectable. That means that the thyroid is not working. So the poor pituitary gland is screaming at the thyroid, to try to, you know, make some thyroid hormone, and the thyroid is not responding. So all of this in summary can be treated by giving levothyroxine. This is actually a presentation of severe hypothyroidism. The question about the pituitary gland, notice it doesn't say a mass or a tumor. It just says it's enlarged. And so again, without a thyroid working, there's no feedback on the pituitary gland. The TSH is 80, so there's some hypertrophy of the pituitary gland in an attempt to get this free T4 up. So really the treatment here is levothyroxine. That is a tricky question, but I like it because you can reason through everything. I think we'll skip this one. It's pretty straightforward in the interest of time. If anybody has any questions, feel free to email me. So let's go on to adrenal crisis. Just to remind ourselves, the GFR, so these are all the layers of the adrenal gland. What I wanted to point out is don't forget that this glomerulosa is actually under renin, so which is not from the pituitary, right? So part of your adrenal gland is being controlled by renin. It's not all being driven by ACTH, and we'll talk about that in a little bit. So the point is if somebody has a pituitary problem, they will still have preserved renin function, whereas if somebody has a total adrenal problem, they'll lose that renin activity. Or not the renin activity, but they will not. If somebody has a primary adrenal problem, the renin will not have a chance to act on the adrenal gland, and that can cause an aldosterone deficiency. So the presentation, the predominant manifestation is shock. So we all kind of know that: anorexia, nausea, vomiting, abdominal pain. Look for hyperpigmentation. So if a person has primary adrenal insufficiency or Addison's disease, that can be associated with antibodies that can stimulate the melanocytes. The ACTH is what stimulates the melanocytes, and that can give you some hyperpigmentation. Hypoglycemia can be seen. And so keep in mind that if this person has their entire adrenal gland is not responsive, remember, they're going to lose that. The renin cannot stimulate the aldosterone production, so they're going to have a mineralocorticoid deficiency. Whereas if it's a pituitary problem, remember, you'd just be losing the ACTH, so the renin can still work, you can still make aldosterone, so you usually don't present with quite a problem as you would if you lost your adrenal gland versus if you had a pituitary problem. This is just to show you some of the hyperpigmentation that can be seen. I had a patient get these biopsied once, and they couldn't figure out what it was. And it was before she presented, and then sure enough, I saw her in the hospital, and she had developed Addison's disease. So the diagnosis would be to make sure that you don't delay treatment while you're waiting for the test. So go ahead and give steroids like right away. If you can, try to grab some blood. So try to check cortisol, ACTH, chemistry, renin, and aldosterone, like, you know, get that, send that off. Do not wait for the results, and just start some glucocorticoids. Down the road, you can consider an ACTH stim test. Usually I would just worry about that as an outpatient, like just put them on steroids, make sure they have good endocrine follow-up, and we can sort it out later. But if patients are taking glucocorticoids, they can only have been on it for a few days. Ideally, dexamethasone interferes less with the ACTH stim test than the other glucocorticoids. But I wouldn't worry about that. Again, give what you have, and then we can always worry about, can we wean down these steroids and worry about the ACTH stim test later. But that being said, if you already sent off the ACTH, that can be really helpful in the setting of hypercortisolism to help us decide, is this a primary or secondary lesion? So wrapping up, I know we're almost out of time, would be pituitary apoplexy. Again, pretty rare presentation, and that's sudden hemorrhage into the pituitary gland. If you're taking boards, it'll be one of the worst headaches of your life. A lot of times, I would say most of the time, I think it's hemorrhage into a pre-existing pituitary adenoma. So interestingly, these tend to occur more in like men, maybe postmenopausal women. And the reason is because premenopausal women rarely get macroadenomas because they start noticing that they have amenorrhea. So women right away will be in my office saying, hey, what's going on? We need to work this up. Whereas men can sit with decades of a growing pituitary tumor and not present with symptoms or mild, you know, hypogonadism sort of things. They can certainly get diplopia because of pressure on the oculomotor nerves. And then what we're worried about would be the hypopituitarism. All hormonal deficiencies from the pituitary can occur. The good thing though is our pituitaries tend to preserve the more crucial functions. So what you're going to tend to lose first would be growth hormone. Once you're an adult, you don't really need growth hormone as much. Prolactin, and then the gonadotropes, and then the TSH. Most pituitary glands are going to try to preserve that ACTH as long as they can, because that's really the thing that can kill you quickly is if you lose your ACTH. So diagnosis is based on the pituitary axis. Unfortunately, imaging is not very good all the time. They can have a normal physical exam, CT scans, MRIs, CSF studies can be normal. Even if there's hemorrhage, they can be overlooked. So it's really, you know, you just have to check the blood and see what you find there. So for the treatment of pituitary apoplexy, high doses of corticosteroids, you know, stress dose at the beginning, and then in contrast, remember, we talked a little bit about the prolactinomas. So if somebody just has a routine prolactinoma, you always want to give them cabergoline or bromocriptine. You want to do medical treatment, not surgical treatment for most prolactinomas. Now, this is different, though, because this is pituitary apoplexy. So if you have that tumor and there's bleeding in it, no, you need to call a neurosurgeon right away. So the sooner they can get decompression, the better. I saw a patient who had unilateral ptosis, like his eye was totally dropped, but unfortunately he waited like 2 weeks to come in, and the neurosurgeon wanted to do a surgical decompression of this old lesion, and I had recommended against it. He did get the surgical decompression and his symptoms did not improve because by that point he had gone 2 weeks with this apoplexy, with the bleed. So we already talked about that. So question would be, a 50-year-old man is seen in the emergency room for a severe headache, double vision, kind of some borderline hypotension, tachycardia. Initially appropriate, becomes more progressively confused. So he has ptosis and hemianopsia on the left eye is in a downward abducted position, and his pupils dilated. WBC is 12,000 and his sodium is low at 131. So what's the diagnosis? I mean, obviously we're talking about pituitary apoplexy. Come on, that was too easy. So obviously I'm not going to just ask you that, but what is the next appropriate step? So again, the important thing is to, you know, do you want to draw the labs? Do you want to treat? Do you want to do some imaging first, some diagnostic lumbar puncture? So, you know, the answer to this would be this, and the key being before the results are back. So like we talked about, go ahead and draw the lab stat, but don't sit around and wait for the results. Go ahead and give some glucocorticoids. Like I said in my first slide, glucocorticoids are good for everyone, right? in endocrinology. Maybe not Cushing syndrome. So go ahead and give the IV glucocorticoids, and then once you get the results, the best case scenario is you could be wrong and whoops, they didn't need the glucocorticoids, but at least the cortisol was normal. So that's all I have. Here is my email. Feel free to email me if you have any questions or anything wasn't clear on this presentation. I just want to point out this is my daughter. This is taken a few years ago. And so it was a pleasure talking with you today. And I look forward to hearing any questions or any further discussion you might have. Thank you.